Welcome to our webinar, Endotoxin, the Phantom Menace of Sepsis, sponsored by Spectral Medical. Before I introduce our moderator and presenters today, I'll just quickly go over a few housekeeping topics. And while I'm doing that, you'll see a poll on your screen to give our presenters an idea of who's in our audience today. Please also feel free to type in the chat where you're viewing today's webinar from. So your audio is automatically muted. If you have any questions for our presenters during the webinar, please type them into the Q&A box on your webinar dashboard. We'll try to get through as many questions as possible at the end. Again, you can access the slides in the handouts section of this course on Sepsis Alliance Institute. Please feel free to download those and follow along. Today's webinar is being recorded and will be available in the coming days. And just as a reminder, we are not offering continuing education credits for today's webinar. Sepsis Alliance gratefully acknowledges the support provided for this event by Spectral Medical. The content in today's presentation was determined by the sponsor. And before we get started, I'll just quickly speak to Sepsis Alliance's mission for those of you who are new to our organization. Sepsis Alliance develops sepsis awareness and education programs. Our mission is to save lives and reduce suffering by educating the public and leading an alliance of patients, healthcare professionals, and partners committed to preventing and curing sepsis. And just as a reminder, the information presented today is intended for educational purposes only. So with that, I am excited to turn things over to the Spectral Medical team to get us started. Our moderator today is Dr. John Kellum, who's the Chief Medical Officer at Spectral. Thanks so much for being here, Dr. Kellum, and I'll turn things over to you for some introductions.
Thank you very much, Hannah. As was stated, I'm John Kellum. I'm a professor of critical care medicine at the University of Pittsburgh, and I am also the Chief Medical Officer at Spectral Medical. Let me introduce you to our speakers. Our first speaker will be Debra Foster. Debra has spent her entire career really working to combat sepsis. She started out as a bedside RN in the ICU and transitioned to designing and implementing clinical trials for patients with sepsis. She currently works as a clinical consultant to Spectral Medical. And joining her will be Mark Tidswell. Dr. Tidswell is a professor of medicine at the University of Massachusetts Medical School. He works with patients at Baystate Medical Center in the medical, surgical, and neuro-intensive care units. He devotes much of his time to clinical research in sepsis and in ARDS. His team has been involved in measuring endotoxin and testing therapies to fight endotoxin for many years. I'll turn it over to you, Debra.
Thank you, John, and I'll just get my screen up and ready for everyone. So here we are. Thank you very much. On behalf of Drs. Kellum and Tidswell and myself, I want to thank the folks at Sepsis Alliance, in particular Hannah, for your excellent organizational skills and getting us prepared for this lecture today. And then, of course, to Tom Heyman, who is the leader of the group and Sepsis Alliance, and a person whom I admire very much. So we are here today to present a topic, endotoxin as the phantom menace of sepsis. And despite the seriousness of sepsis as a disease, I'm going to take the opportunity to have a little bit of nerdy fun with our title and just describe how endotoxin can truly relate to the phantom menace, such as in episode 1 of Star Wars, one of my favorite movies. And so in choosing this title, I will explain the analogy as I see it, and hopefully you'll be able to relate to it as well. And so if we start with the literal definition of phantom menace, we can see that it is a hidden or an unseen threat, elusive danger. And so when we talk about the gram-negative bacteria that you see here, in that regard, it truly is a phantom menace. And so in Star Wars, you can sort of visually interpret a phantom menace when you think of Anakin Skywalker and Darth Vader, and then, of course, Senator Palpatine becoming Darth Sidious. Each goes through a transformation from good to evil. And how does that happen? Are they external forces that contribute to the transformation, as was sort of explicitly detailed in the movie? Or was it from an internal source, which has turned out to be really the true cause of this transformation to the dark side? And so when you look at a gram-negative bacteria, here is a representative sample. It's a vibrant blue rod-shaped bacteria. What kind of transformation must it undergo in order to take a perfectly healthy human being and have them end up in the intensive care unit with multiple organ failure, on organ support, and in septic shock? So today, what we're going to talk about is, what part does endotoxin play in the etiology of sepsis and septic shock? The seminar will describe the human response to elevated levels of endotoxin, both as an adaptive immune response, but also as a trigger of sepsis. The ability to measure endotoxin activity in the bloodstream allows us to uncloak its true prevalence and closely examine endotoxemia in sepsis. Can triggering endotoxin removal be a successful treatment modality for sepsis? And with that, let's begin. Dr. Tidswell?
Thank you, Deborah. Well, what is endotoxin? It's really part of the outer wall of gram-negative bacteria, bacteria such as E. coli, Klebsiella, Pseudomonas, and many others. Gram-negative bacteria are incredibly important. For example, they're part of our microbiome of our GI tract. On the other hand, endotoxin can be deadly. Endotoxin is a lipopolysaccharide. It's also known as LPS. In particular, the lipid A portion is the active portion of LPS. It is a toxin. Even a very small amount can make a person sick or lead to death. It's part of the bacteria and not usually released as a toxin, but fragmented bacteria can shed lipid A in particular. Endotoxin is really unique to gram-negative bacteria. Nothing else has this. And the lipid A portion is highly conserved, very similar among gram-negative bacteria. And next slide. Thanks. So detecting endotoxin would be really beneficial as an early way to detect invasion by gram-negative bacteria. And so it's an important immune function. An early response to even a small number of invading gram-negative bacteria could help us fight off infection early, before there was a major infection that became established and harder to get rid of. We know that we have an innate immune system that's already pre-programmed to recognize bacterial molecules like endotoxin. And endotoxin is a significant trigger of the innate immune system. One major protein receptor for endotoxin is TLR4, also known as toll-like receptor number 4. And certainly in mouse models, without TLR4, the ability to detect endotoxin, gram-negative bacteremia is fatal. Now, TLR4 is found on white cells in the circulation and on many different cells and tissues throughout the body as a way to early recognize endotoxin and gram-negative invasion. Next slide. In normal humans, so this is a laboratory model, even a small single dose of purified endotoxin will create signs and symptoms of sepsis. So endotoxin will produce fevers, chills, myalgias, and showing here is over, I don't know if you can read the axis there, but it's over 8 hours in each of the figures. Temperature goes up, peaking around 3 hours, heart rate goes up, mean arterial pressure decreases, systemic vascular resistance decreases with a concurrent increase in cardiac output. And these are in healthy volunteers given a single dose of endotoxin. In addition, there are changes in white blood cell counts, CRP, tumor necrosis factor, and other things. during gram-negative bacterial infection, higher levels of endotoxin are present and prolonged exposure to endotoxin, and this can lead to multi-organ failure. This can be seen as hypotension, shock, ARDS, acute respiratory distress syndrome, acute kidney injury, and disorders of thrombosis like abnormal clotting. Every organ can be affected. And next slide. It is it's really remarkable that we don't have more often bad reactions to endotoxin, because gram-negative bacteria are all around us in the environment, and we have 1 trillion bacteria helping out with digestion in our GI tracts. So how does a little tiny quantity of endotoxin turn deadly in sepsis? Well, endotoxin, first of all, can come from a couple of sources: externally through bacterial invasion. So pneumonia, urinary tract infection, bowel perforation, even an infected device like a central line. And endotoxin can also come from an internal source. Again, there's 1 trillion bacteria in our intestines. During low blood pressure, such as shock due to infection or trauma, even hemorrhage, bacteria or endotoxin can enter the blood. So translocation of bacteria or bacterial lipid A is not necessarily the whole bacteria from the gut, but translocation can occur, and then we are exposed to endotoxin. Next slide. Toll-like receptor 4 and other immune receptors then recognize endotoxin, and they're present on many different types of cells, including tissues and circulating white cells. So after just a few molecules of endotoxin are detected, very quickly thousands of genes are upregulated. And then many genes express different proteins, including inflammatory cytokines, but also transcription factors that turn on other genes, and enzymes that control metabolic activity. Next slide. So as a result, there is local inflammation at the site where endotoxin is first detected, but also this often leads to a whole body or systemic response to inflammation. And the amount of inflammation can range from local to multi-organ failure to septic shock, and these later stages carry a high risk of death. Hypotension, vasopressor dependency, multi-organ failure manifested with a high SOFA score. Next slide. It's also been known for some time that endotoxin is present in patients, of course, with gram-negative infection, but in addition, endotoxin levels can be high in other forms of shock, such as infection due to gram-positive bacteria, fungi, or even if there's a cause of shock that's non-infectious, such as trauma or hemorrhage. And again, this may be due to translocation of bacterial endotoxin from intestinal bacteria. What's also clear is that endotoxin is detectable in patients with shock, and when it is, outcome is worse and mortality is higher. And that's what's shown in this graph from 20 odd years ago, showing that patients with detectable endotoxin in the bloodstream had a less likely chance of survival. So because of its known effects on humans and the association with the risk of death, finding a way to remove or reduce endotoxin could be an important therapy. Now, again, endotoxin in the bloodstream does not necessarily mean there are gram-negative bacteria in the bloodstream. It can be found with any type of shock, even gram-positive infections. And again, it's likely that there's translocation of endotoxin from the gut. Because of the potent effect on patient physiology, and again, because of worse outcomes, there's an incentive to try to find therapies that can remove endotoxin. But in order to know which patients might benefit from endotoxin removal, we need a rapid assay that can measure endotoxin in the bloodstream of patients. Deborah?
Thanks a lot, Dr. Tidswell. So yes,
Sure.
it's true that while septic shock is deadly, and endotoxemic septic shock even more so, all patients with sepsis do not necessarily have high levels of endotoxin. And so in that regard, endotoxin is truly a phantom menace, as it is unseen and elusive. Until now, with the endotoxin activity assay, we're able to actually reliably measure endotoxin in whole blood samples in patients. And it has had FDA approval for such an indication for many years now. So some of you in this webinar may have experience with its use. I know Dr. Tidswell's team run many EAAs in their lab. And so let me tell you a little bit about how this works. Now, endotoxin measurements, and endotoxin has been elusive in terms of an inability to come up with a method for measuring. For many reasons, it's a very difficult molecule to measure in an assay. So this method is rather unique and not like many other tests. It uses the platform of chemiluminescence, and chemiluminescence really means light emission over time. And that little blue box on the right is a luminometer, and that measures the light emission over time. So the way the assay works is one of its key reagents is an antibody to lipid A. As Mark mentioned, the most highly conserved as well as lethal component of endotoxin of a gram-negative bacteria. And so this antibody is got very high affinity for lipid A of endotoxin. So in a patient sample, as may be represented here in the larger box, bit of a cartoon of what happens inside the test tube with the whole blood. So if there is any endotoxin present, the antibody reagent will cling to that very closely and present it to a PMN, so a neutrophil or a macrophage or any type cell. That cell will engulf the antigen-antibody complex, and then through a series of chemical reaction, release an oxyradical, a negatively charged product that in the presence of another reagent, a lumiphore, combines to give off a photon of light. And so for each antigen-antibody complex, there's one photon of light emitted. And so a graphical representation of how this is measured is with this graph in this slide. And so the tubes on the left represent the 3 tubes that are part of the endotoxin activity assay. Whole blood is aliquoted into each of those tubes. And tube 1 really is considered a blank. What it tells us, as per the red line in the graph, is what is the baseline state of activation of the white cells in this patient's particular sample. And so in this case, it's very low. It's not a highly stimulated neutrophil. Then in tube 2, we have the antibody, a known quantity of antibody as its reagent. But tube 3 has an excess of endotoxin. And so in that tube, it's whatever the patient concentration of endotoxin in the blood is, as well as the reagent additive that we've included. And so when you look at the graph, that black line represents a maximum amount that those patients' neutrophils could respond to a maximum amount of endotoxin. So then the important component of this graph is the blue line, because then the blue line tells you the difference between a 0 reaction, like in the red line, and a maximum reaction, as in the black line. So in this particular case, this patient sample has a very high level of endotoxin, as its concentration is very high, is very close to the known high concentration in tube 3. And here's how we then report these results. It's a semi-quantitative test, which means the results are reported as a low, intermediate, or a high level. And a low level is determined as a very low likelihood that a patient has sepsis. A high level, on the other hand, is a very high likelihood. In fact, it's an odds ratio of 3 times higher than patients with low levels, that this patient has severe sepsis or septic shock. And another important association then with knowing that a patient has a high level of endotoxin is not just their association and likelihood for having sepsis, but it's also related to the potential for high mortality. So it also is a risk indicator for this particular patient in terms of their ability to survive their ICU stay. So this data comes from the Menace trial. It was run in 4 different countries, published in 2004, as you can see. So this actually has been around for a little while. These were patients, almost 1,000 patients in a number of ICUs in Europe, Canada, and the US. And so this is really the first piece of evidence that has established what the endotoxin activity can provide in terms of information at the bedside. One of the other things that one does when developing an assay is look to see if what you're measuring can be removed by something that is known to be able to remove that analyte. So for example, it's known that endotoxin is highly reactive with polymyxin B, an antibiotic, polymyxin B. Yet polymyxin B is dangerous if it's given intravenously. And so although it's highly available in terms of its topical use, so most of the topical antibiotic ointments contain polymyxin B. It's not used any further in the ICUs as an intravenous form. So in this, what we did in this experiment is the red bars represent 9 different patient samples. These are sick patients in the ICU. They all have very high levels of endotoxin. The yellow bars then are the same levels measured by the EAA following polymyxin B, a small amount of polymyxin B put into each of the test tubes. And so this helped confirm that, yes, this is endotoxin we're measuring, because certainly polymyxin B, in the presence of polymyxin B, endotoxin levels go away. And so this is, great news in terms of we know a lot about the antibiotic polymyxin B, but unfortunately can't be used in patients who are very sick until recently. And that recently is relative, recently for North America, that is. And I'm going to turn this over to Dr. Tidswell once again, who will explain how polymyxin B can be used now as a therapy for patients with high levels of endotoxin in the bloodstream.
All right, thanks, Deborah. As you were saying, polymyxin B is a naturally occurring antibiotic, has the ability to interact with endotoxin. Many of you probably have a tube containing polymyxin B as an ointment in your medicine cabinet, but polymyxin B is thought to have toxic effects if it's given intravenously. On the other hand, there is another approach. Polymyxin B, or PMX, can be bound to fabric fibers and then rolled up into a cartridge. Blood is then passed through this cartridge and endotoxin binds to PMX. In this way, the PMX stays within the cartridge, but clears endotoxin from the bloodstream. And this innovative approach to remove endotoxin was approved in Japan in 1994 and then in Europe in 1998. Here is a picture of the PMX cartridge and a schematic for what it would look like to use this extracorporeal removal of endotoxin. Next slide. Can you advance the slide? Thank you.
There, can you
Oh,
see
great.
that?
Yeah, this is from a systematic review in 2007, looking at published clinical trials of PMX. And there were approximately 1,000 patients who had endotoxin removal with PMX, and they were compared to patients who were treated with conventional therapy. Overall mortality was about half in the treated patients, 33%, compared to 66% in the patients who did not receive endotoxin removal. And there were other important findings. From left to right, mean arterial pressure was increased. The use of, or the need for vasopressors was decreased. PF ratio, improved lung function was increased. Endotoxin levels decreased, as you might expect. And again, overall, there was some improvement in mortality. Next slide. In 2009, a randomized controlled trial from Europe was published. Now, the UMASS trial, and I'm showing here in the graph the mortality in the conventionally treated patients and the PMX treated patients. This was a study in 10 Italian hospitals. They enrolled 64 patients. These patients had intra-abdominal sepsis and emergency surgery. There was a plan to enroll 120 patients, but the study was stopped early because it looked like there was a clear-cut benefit. 32% mortality in the PMX treated group and 53% mortality in the conventionally treated group. Now, many of us wish they had finished the trial, but at that point, it seemed to the investigators and the DSMB that it was important to stop and allow this therapy to be more widely used. There are also improvements in SOFA score and mean arterial pressure. After this UMASS trial, there was a registry mostly in Europe, 357 patients, and this follow-up registry was real-world experience. And you can see there that in what's called the UMASS 2 trial, again, 57 centers throughout Europe, this time with intra-abdominal infection, as well as respiratory and other infections. You can see that the registry mortality is about the same as the PMX treatment group in the randomized controlled trial. So real world data that looked like it was as good as the clinical trial. And in the table are the changes in SOFA scores for the patients in the registry trial from time 0 to 72 hours. So there were improvements in overall SOFA score, cardiovascular, renal, respiratory, and coagulation. However, the hepatic SOFA did not improve, and there was a decrease in the number of platelets. But overall, the registry suggested that it was feasible and safe in septic shock to treat with PMX in the real world. So following these studies, a large randomized control trial was conducted in the US and Canada. This was called Euphrates trial. This study enrolled adults with all types of septic shock, GU, respiratory, abdominal infection. The patients had to have an elevated EAA. So this was done with a lot of input from spectral. And they had to have a multi-organ dysfunction score, or the MOD score, greater than 9. Treatment was randomized, and the clinical teams were blinded to treatment assignment. In this study, there were 450 patients that were enrolled. They were randomized 1-to-1 PMX cartridge to sham treatment. The PMX treatment was 2 sessions lasting 2 hours on 2 consecutive days. The PMX treated group had an improvement in mean arterial pressure and days free of mechanical ventilation. However, in the Euphrates trial, 28-day mortality was no different, 44% in both groups. Now, review of the data in the Euphrates trial indicated that perhaps too many patients were too sick and with too high an endotoxin level to expect that the PMX treatment would successfully improve their outcome. So David Klein, Debra Foster, and several others analyzed the Euphrates data further. They noticed that there were a number of patients with very high EAA, greater than 0.9 in each group, and it was at least 1/3 of the patients. If these patients were removed, then reanalysis of patients who had a high EAA but not too high, 0.6 to 0.9, showed that there was a mortality benefit of 10%. And the 10% difference in outcome, 10% more survivors, was sustained throughout 90 days of follow-up. So with this in mind, and learning from the previous trials, a new study was created. This is the Tigris study. It's currently enrolling adults early in the course of vasopressor-dependent septic shock. Patients have a MOD score of greater than 9 or a SOFA greater than 11. They have an EAA that's above 0.6 but less than 0.9. So an EAA that's high but not so high that it would predict fatality or beyond the capacity of PMX to remove with 2 2-hour treatments. This is an open label study. It randomizes patients 2-to-1 to PMX, and the plan is to enroll 150 patients. 25 sites in the US. Now, the good news is this has been going on for some time, and so far 132 patients have been enrolled in Tigris. So we're very close to the end. Next slide. This slide is to point out that the worldwide experience with PMX is very large. Much of the experience is from Japan. It's been available there for 30 years now, and it's available from randomized controlled trials, observational studies, and national registries. There is a prevailing opinion that among those people who use PMX that it's beneficial. But to this point, phase 3 studies in the US have not been convincing. PMX is not yet part of the sepsis bundle and is some part of the recommendations for surviving sepsis campaign. Hopefully, Tigris gets the patient population right. It's important to remember also that the experience is so far in over 200,000 uses, and that PMX has been shown to be safe with a very low rate of complications, somewhere around 0.01% with transient hypotension and a decrease in platelet count. So how would PMX fit into an algorithm for sepsis care? So as we get nearer to the end of the Tigris study, we're trying to visualize how to include PMX in an algorithm. In Europe, where the treatment's already approved, the Italian Society of Anesthesia and Critical Care suggests this algorithm: an initial resuscitation, so the 1-hour bundle, measuring lactate, blood cultures, administering fluid, considering vasopressors if needed, targeting a MAP greater than 65, and administering broad-spectrum antibiotics. Subsequently, the next step would be, if there's still refractory shock based on lactate or need for vasoactive medication and a high SOFA, then do an EAA test. If the EAA test is elevated, step 3, so a value between 0.6 and 0.9, at that point, you would consider hemoperfusion treatment with PMX. And the treatment, again, would be what we're using in Tigris, daily for 2 days, 2 hours each treatment. And so we're looking forward to the conclusion of the Tigris study. We hope to find out whether PMX is effective and really ultimately whether we have a new way to fight off endotoxin in septic shock. And Deborah, do you have any additional comments, please? chime in.
So Hannah, let's have a quiz, and Dr. Kellum can be the moderator here.
I get to play Jeopardy, I guess, and be the host. So sure. So I think the question you see in front of you, I won't read it because I think it's a short set of questions, and I'll let you go ahead and take a minute to fill in your answer. I see we're at about 30% in, so I'll give you another 60 seconds or so. This is a smart bunch. Looking at the results as they come in.
Great.
Okay, we'll go ahead and end the poll there, and I will share the results with people. And as you can see, you get a star. It's all of the above. And I think, as was made clear in the presentation, I hope this is a bit of a transformation in our understanding of endotoxemia in human beings over the last few decades. For a very long time, there was sort of equivalence given to endotoxemia and gram-negative infection, and the understanding that it's actually not the infecting organism in much of the time, but rather is coming from translocation from the gut, as well as a bit potentially from the lung as well. There's some data showing gram-negative infection in the lung. You can translocate from there as well, but I think most of it's coming from the gut, and that's a change in our understanding of this disease process over time. And I think, do we want to ask the second question as well, which is on the right-hand side of your screen?
That was on a scroll down on that one, John. So I think if you scroll
Oh,
down there, you
was
should be
it?
able
We
to see the
already answered
results as
that.
well.
Well,
Yep.
there we go. So hopefully you can see that. So that's great as well. So the ongoing study is Tigris. This is a bit of a play. Obviously, the UMASS was an acronym, and Euphrates was a little bit more of a sophisticated acronym. It happened to be the name of a river in ancient Mesopotamia, now Iraq. And Tigris was the new trial as a way of staying with that theme. Interestingly, just a bit of trivia, the Tigris and Euphrates are two of the historical rivers that were meant to have bordered the historical the biblical Garden of Eden. And so we have an observational study that will be coming out in a few months that also took place. Dr. Tidswell was a member of that team, and we measured it. EAA and organ dysfunction across an observational cohort to gain greater insight of the range of organ dysfunction that occurs in endotoxemia, and that should be coming out in a few months. So you can look for that, and you can know when someone asks, why did they call it Eden, that the answer is it comes from that story. So very good, very good. I think we're ready for the Q&A at this point, I believe. Is that right?
Yep,
Great.
let's do it.
So thank you all.
There are some questions in the chat as well as.
I see that, and I think I'll use sort of moderator's discretion and combine a couple of questions and start with this one, and that is that several people ask about the EAA, so this will be toward you, Deborah, although Mark's got a lot of experience as well. But the questioner is asking about work in cancer patients, for example, who are neutropenic. How well does the test work in that setting? That's particularly important, obviously, because this is an area where patients are at high risk for endotoxemia.
Yeah, that's an excellent question. Thank you, because it's true, the neutrophil is the reporter molecule in the EAA. So what we've found is that For patients who are severely neutropenic, the test won't work. And the test has a built-in sort of mechanism that will let you know whether or not it's going to be able to provide a valid result. And so even though in our package insert we say the most reliable measurements come when the patient's neutrophil count is 500,000 or greater, we do find that we can get some results with patients who have lower levels of neutrophils. And the way you know is that if there isn't enough of a difference between tubes 2 and tube 3, and there's some technical reason behind that, you'll get something that's called an NR or a non-responder. So non-responder is a non-result, and that means that you couldn't use the test in that particular patient.
Very good. The next question relates to the therapy and wondering about whether there's been any pediatric experience. Debra, maybe I'll start with you there because I know you spend a lot of time every year reporting the world's literature to FDA. So you have a lot of time spent reading those papers.
I do, thank you. And yes, in the slide that Mark showed of the 498 published articles since the first study using PMX in patients in Japan came out, they're all summarized in a document that Spectral has called the Report of Prior Investigations. And so it's like a investigator brochure for device trials. And we've had 14 years of review of the literature during both the Euphrates and the Tigris trials. So I can tell you that, yes, there is quite a bit of experience now outside of North America of pediatric use. Now, I'll mention a couple of things here. One is the cartridge is manufactured by a company in Japan called Toray Industries. The cartridge that we were talking about here is one that's intended for adults. And what that means really is somebody who is over 37 kilograms in terms of the mechanisms of the test, so that there's 135 mils of blood displaced when you use the adult version of the PMX cartridge. And so for some hospitals outside North America, they'll use the adult version for some of the larger pediatric patients. But Toray has also now manufactured a pediatric version. And so it's exactly the same method for production, but it's in about a third of a smaller cartridge. And so if you have a smaller child or even an adult that's less than 37 kilos, one could use the pediatric version. And also they have a tiny neonatal version as well that hasn't made it out of Japan as far as I know yet, but perhaps that's something that we can look forward to down the line as this product hopefully will go forward in the United States.
Very good, very good. Next question, I think, Mark, is for you, at least to start. Some questions about how the intervention is actually delivered, and is it through like a regular dialysis CRT machine? Can you give some details about how that all works, and then maybe also comment about kind of related to that, how you see this rolling out in terms of standard of care, and what are the barriers to sort of general adoption?
Sure. Well, we have run it on a regular dialysis machine during the Euphrates study, and lately doing it with a CRT machine, which has been easier. When we used the regular HD machine, we had to have one of our dialysis nurses do it, and now we have the bedside ICU RNs run the procedure. We happen to use a machine that's manufactured by Baxter, and we're currently looking at different ways of delivering the treatment with that machine. But it's fairly easy to set up. I think many of you who are familiar with CRT know that it's a simple cartridge that snaps onto the front of most of these machines and can be set up and run pretty quickly. There is because the cartridge has a fluid in it as a preservative, it has to be rinsed with saline for about an hour. And so during that setup time, there is a little bit of a delay. And of course, during research or clinical research, there's a whole process of obtaining consent and talking to families, making sure that everything's clear, giving them time to consider whether this is the right thing for them to do. If this were approved for clinical care, would just simply be a shorter conversation, if we could guarantee that there was a positive effect, I think people would be more likely to move ahead with it. The only other step is insertion of a dialysis catheter. It's usually a temporary dialysis catheter in one of the larger veins, either femoral or internal jugular. And so that takes a little bit of time, but it's a standard temporary dialysis catheter, standard machine, and it's been a pretty straightforward process.
Thank you, Mark. Debra, this is a great question that I think you probably would like to answer. And a questioner wants to know about the use of this in sepsis that's occurring in pregnancy or in the peripartum period. And I know we have a rather sensational case that occurred and was actually a TV interview some years ago. And maybe you'd like to talk about that.
Yeah, no, that's a really important subset of patients with sepsis where we do have experience with use of the PMX cartridge. Now, in terms of women who are pregnant with a viable fetus, that right now is not part of the indication because, there could be, again, some unknown factors that occur when you displace 135 mils of blood in a woman who's unstable and has a viable pregnancy. But we don't consider a positive pregnancy test as an exclusion criteria for the trial. And here's why. So the experience that we do have is in women who either have had complications with sepsis and are pregnant and end up losing the baby. And the experience that the specific experience that John mentioned, yes, was the subject of a TV feature in New Jersey. This was a woman that was in the Euphrates trial, and she was on vacation with her husband. First vacation together after the birth of their first child, and they had a great time. They came back. The woman was unwell and also pregnant. So she'd been refused. Well, I shouldn't say refused. She wasn't taken super seriously for the first couple of visits to the emergency department. Finally, in extremis, she got admitted at one of the hospitals where we were running the trial. She met all the inclusion criteria, and she actually was randomized to get the PMX cartridge. So she underwent the 2 hours of therapy twice in a 24-hour period, and she ended up going home. And within the year following, she was pregnant again and had a very healthy and happy baby. And so it's such a great story because this woman who really had a very high likelihood of a bad outcome went on to recover, and went on to actually be able to have more children. So that was a very heartwarming story. But we have others where we did have women who were peripartum and had septic complications, but we did include them in the trial, and they've had very good outcomes.
Thank you, Deborah. Another question from the audience involves the relationship between the sort of efficacy of the treatment and the timing of intervention. And I know you've thought a lot about this, both of you, so you may want to both comment about this. I'll just say the trial itself has a restriction on the number of hours a patient can be in shock. 30 hours is how we set it, so that we're not trying to treat patients that are really been in this endotoxic septic shock period for too long. But maybe some ideas about the relationship between timing of intervention and outcomes. We can start with you, Deborah.
Yeah, well, with any intervention in sepsis, the earlier the better. Now, one of the things that we are a little bit careful about in our trial and the inclusion criteria is this is really kind of a last stop. It's not meant for patients who will respond to the 1 hour bundle with fluid resuscitation and antibiotics who are then seeming to get better. This is really then for that group of patients who does not initially respond and begin to have evidence of organ dysfunction. But even still in that group of patients, it's always the earlier the better. And yes, the setup takes, well, between running the EAA, which takes about 40 minutes, and then setting up the hemoperfusion device, which again is about another 40 minutes. That's, a little over an hour of time. Time is tissue, right? And when these patients with sepsis, so it's always most important to try to get the team lined up as quickly as possible to provide the intervention.
Mark, do you have any insight on that as well?
I haven't really looked at our patients in terms of outcome and time to treatment, and obviously I'm not aware of the entire group at this point. Again, it's unlikely that it would be any slower in clinical practice. There's some hurdles that you have to get through in a clinical trial. The consent process, families want to look at it over coffee, talk to their PCP. And for us, we also have to bring in an RN who's outside of the not taking care of the patient to run the machine. So there's some hurdles, but I think that were this to be translated into clinical practice, it would be much faster. So we're always pushing up around 24 hours.
Right. Good. We have just a couple minutes left, and I've been sort of holding this basic science question. That's a good question, but a bit of a tricky one. So I'll just throw it out to both of you. It really sort of involves your discussion on the adaptive immune response and the trigger that endotoxin produces. And so can you explain the immune system and how it differentiates between a sort of a protective response where it goes after the gram-negative bacteria with this immune response versus one that leads to septic shock? How do we understand that? And I guess it kind of fits a little bit with your duality of good and bad that we sort of talked about in this lecture.
Well, I'll try. I think as a physician, non-immunologist, but somebody who sees this all the time, I think we are always surprised when patient A, who's who has gram-negative bacteremia, say, is in the ICU and on multiple pressors, and patient B, who also has gram-negative bacteremia, is on the ward just getting antibiotics and maybe ambulating and having lunch. And so there's a lot of individual variation, I think. It may have to do with medical comorbidities, chronic illness, how long the infection has been present. Obviously, the site of infection could make a big difference, whether it's a deep-seated pneumonia or a more simple genitourinary infection. There's likely also a difference in terms of how much endotoxin the person's exposed to. And then I suspect there are also individual variations in terms of some of the receptors for endotoxin and how they produce a response. Deborah, do you have any thoughts along those lines?
No, just that more and more is being recognized in terms of the heterogeneity of the patient population that is sepsis. There's different segments that display not just different types of organ dysfunctions, but over different time frames. Is this a genetic situation? Is it a comorbid situation? Is it an age-related phenomenon? I think it's maybe all of the above. And so what we're saying with the ability to recognize when endotoxin is part of septic shock, that this is a segment of the population that, as we've seen, has very high, very lethal chance of or episode of their septic shock, but that we hope we can bring a treatment once our trial is finished and we go through the post-trial situation. So it wouldn't be for everybody, but it would certainly be for that segment that has this specific sort of phenotype of high organ dysfunction, high endotoxin levels, and really vasopressor dependent.
And I'll just add to that, because I think one of the things that people may not really appreciate is that the difference between a device that removes endotoxin from the bloodstream and a pharmacologic agent that, for example, were to manipulate the immune response to endotoxin, there's no decrease in the white blood cell ability to recognize endotoxin, go find it in the tissue, go combat it in the lung, wherever the bacteria are. This device does not in any way impede that function. And so I think that's important because there is a duality of endotoxin. It is a trigger for the immune response, and we don't want to make that go away. And so removing it as a toxin from the bloodstream still allows for white cells to do their job in fighting gram-negative infection. So excellent questions, excellent discussion. Really nice to see such a large audience and active participation. I want to thank our speakers, and I want to thank the Sepsis Alliance for organizing this excellent symposium. Thank you all, and don't get sepsis.